Well, thank you for the invitation to speak on CFTR modulators. I'm not used to speaking to this sort of audience mix, but I'll try to make things understandable and without sacrificing rigor or accuracy. So what is a CFTR modulator? The goal of CFTR modulator therapy is to rescue the function of CF-causing mutant CFTRs. On the left shows a normal cell with CFTR at the apical membrane. CFTR is the red squiggly thing. In the normal cell, CFTR functions as a chloride channel to allow chloride to move out of cells. On the right, when CFTR is unable to function at the membrane, either because it never gets to the membrane or because it gets to the membrane but is not gated properly, that is, does not open, chloride cannot move out of cells and leading to the disease manifestations, including viscous secretions, mucus buildup, infection, and so forth. So the goal of CFTR modulator therapy is to make the cell on the right look like the cell on the left. A few background slides. CFTR is a cyclic AMP regulated, turned on chloride channel. It's a big, complicated membrane protein with membrane spanning domains and domains inside of the cell. Many people have tried to look at the structure of CFTR, and the best guess is shown here. This is the membrane spanning part of the CFTR molecule. In the cytoplasmic domain resides phenylalanine 508. And as you know, delta F508 is the most common CF-causing mutation. CFTR is expressed in the lung, in the airways, pancreas, intestines, testis, and many other tissues. And as you know, loss of function mutations produce CF. And now there are more than 2,000 loss of function mutations. What you may not know is that CFTR is activated in some secretory diarrheas, and it promotes cyst development in polycystic kidney disease. So I'll tell you about the history of CFTR modulators, and I'll interweave within the history my own personal interaction with CF and CFTR. So we'll begin in the previous century. In 1980, while a student at Harvard Medical School, I first was exposed to CF. I did a 3-week rotation at Children's Hospital Boston on the CF ward. And at that time, the median life expectancy was under 20 years of age, and the only available therapeutics were rudimentary antibiotics, airway clearance, and pancreatic enzymes. And a lot has changed since then. I then came to UCSF after completing medical training at the Brigham and Women's Hospital at Harvard. And at UCSF, for completely unrelated reasons, we were looking for a fluorescent indicator of chloride. And obviously, chloride is what's important in CF. And in 1987, we published this paper of a fluorescent probe useful to measure chloride. And at that time, we hadn't begun CF research. And of course, soon thereafter, in 1989, the CF genetic defect was discovered. That is a loss of function mutation in CFTR. And it became soon apparent that the problem with CFTR in CF was that it did not transport chloride. So in the following few years, in the early 1990s, we thought, why not apply what's done for drug discovery for many other diseases to CF? And the way the drug discovery process works is to take up to tens or even hundreds of thousands of chemicals, drug-like chemicals, test them individually against some target, in this case CFTR, using compounds, many compounds, robotics, and then from the assay identify hits, compounds that have activity against a target. And then by laborious medicinal chemistry, it's possible to improve the hits, select leads, and develop an actual drug. So the drug discovery process, the preclinical component, is relatively inexpensive, generally under $5 million, and takes only a few years, as short as a year and a half. IND stands for Investigational New Drug Application, which, when approved by the FDA, allows for clinical trials. The clinical development phase is more prolonged, generally 6 years or more, and much, much more expensive to do phase 1 through 3 clinical trials to develop a drug. Now, in the late 1990s, recognizing that what we needed was a good assay of CFTR, and the original assay we had wasn't so bad, but not really suitable for high-throughput screening, we came up with a method to measure chloride that was suitable for screening using a long wavelength, very bright fluorescent indicator, where in the data shown here, if we add iodide, we see a very large drop in signal when CFTR is active. So it was robust enough for high-throughput screening. So around that time, I proposed to Bob Bell, the then CEO of the CF Foundation, that we should do screening. And I had a visit to the CF Foundation where Bob Bell and the other leaders of the foundation were present. And I distinctly remember the meeting because about 10 minutes into it, Bob Bell nodded off. And in retrospect, it turned out he was just being started on propranolol, and one of the side effects is somnolence. But anyway, by the end of the hour presentation, Bob perked up and said, "This is what we've got to do, and what would it cost?" And so he funded us for instrumentation, compounds, and a generous supply budget to do high-throughput screening. So now we move on to the 21st century. Soon thereafter, I mentioned we found a compound that was useful for high-throughput screening and measuring chloride. Here we found a method that was ideal for screening, a genetically encoded fluorescent protein. And the way this works with the original fluorescent protein and a modification shown at the bottom is that iodide, which passes through CFTR, quenches, that is, drops the fluorescent signal very strongly, even a small amount of iodide. So we could take cells with a sensor, with CFTR, and do screening. And so using that, we looked at inhibitors and activators of normal CFTR, as well as potentiators and correctors of mutant CFTRs. And I'll start with the former, inhibitors and activators of normal, that is non-CF, CFTR. And Bob Bell and the foundation very strongly discouraged us from working on this because obviously it doesn't help to have an inhibitor of CFTR that would cause CF. But I'll try to convince you in a few minutes this was a worthwhile endeavor. So our screen was as follows, and I'll just take you through this because the screening method is very similar for all of the different drugs we've discovered. In this case, shown at the upper left, we have cells with our YFP, our halide sensitive indicator, with human wild type, that is normal CFTR. We activate CFTR, add a test compound, and now we've looked at more than 300,000 compounds for CFTR inhibitors, then add iodide. When the channel is open and we follow the signal in a single well of a 96 well plate, and this is done over and over again, the signal drops quickly. If the signal drops less quickly, it means CFTR has been inhibited, and this is a potential drug candidate. And turned out for the inhibitor screen, very few inhibitors could be identified. It's a tough screen. But we published in the JCI way back in 2002 the first inhibitor of the thiazolidinone chemical class, CFTR inhibitor 172, and this has been used very widely in many thousands of studies and papers to study CFTR function. Subsequently, we identified a couple of other inhibitor compounds. The best one is this one in the red box, BPO27, and this is actually a compound in development. I'll come back to in a few minutes. So what are they good for besides being research tools? Well, inhibitors, based on what I said earlier, are potential therapeutics for secretory diarrhea, the most severe being cholera and several other types of diarrhea. Also useful for autosomal dominant polycystic kidney disease. In contrast, activators of the normal CFTR are useful for constipation, opposite of diarrhea, dry eye, and maybe some other disorders. So let me tell you, for example, the GI indications. In the intestine, this is the lumen facing the inside of the intestine. CFTR is on cells called enterocytes. In cholera, for example, CFTR becomes activated, chloride is secreted into the intestine, water follows, and hence severe secretory diarrhea. So an inhibitor would have therapeutic efficacy. In contrast, for constipation, treatment of constipation could be by slightly activating CFTR, by what I like to call producing very controlled cholera. And by doing so, hydrating the stool in a manner much more effective, say, than Miralax polyethylene glycol. So we did a screen for activators. I won't go through the details. And we found many such activators. This was way back in 2002. And we optimized the activators and tested them for constipation. And this is some recently published work. And the top one is our paper, CFTR activators increases intestinal fluid secretion and normalizes stool output in a mouse model of constipation. And this was followed by a very nice review and editorial by Wayne Lenser at Harvard Children's Hospital entitled Opening CFTR in the Intestine, Flushing on Demand, which exactly describes the mechanism of action of opening CFTR in order to hydrate the stool. So what we subsequently did is publish a series of papers showing proof of concept for diarrhea, polycystic kidney disease, constipation, and dry eye. And based on this package of material, including optimized lead candidates for development, we approached a number of companies and ultimately signed a license agreement last year with Vanda Pharmaceuticals in Washington, D.C. to develop our whole portfolio of activators and inhibitors of wild-type CFTR for constipation, diarrhea, dry eye, and PKD. Now let's turn to what's relevant in CF, potentiators and correctors. We began looking at the obvious mutation, the delta F508, because it comprises by far most of the CF patients worldwide. Although as we go along, I'll talk about many other mutations specifically and in general. So we introduced the general paradigm in the early 2000s of potentiators and correctors. And what it's meant to mean is specifically for the delta F508, this protein is misfolded and very little is made. It's rapidly degraded. A corrector drug helps the protein get to the membrane, but it's still not perfect. It's still not open. A potentiator drug then opens the channel. And so an obvious question is, why not have a single drug that does both? And we've not been able to find that. So the easiest thing is to individually correct the trafficking, the transport, and correct the gating, the ability to open the channel. So let me begin talking about potentiators. Turns out the very first potentiators discovered by screening were reported in our paper on normal CFTR. This shows figure 6 of our paper. We happened to look at whether the molecules we identified would also serve as potentiators, that is, normalizers of the defective gating of the delta F508 CFTR. And the answer was yes. As shown here in the box, several of these compounds, this one being extremely potent, were able to open the cystic fibrosis causing mutant. And then immediately thereafter, in 2003, we published a paper using a screen specifically on delta F508. So as shown on the left, we take cells with this CFTR mutant and the YFP indicator, and we add a test compound and look for the ability of the test compound in the middle to open the channel and have a more rapid drop in signal as iodide enters cells. And we found many potentiators. Out of 100,000 compounds, nearly 70 or 80 were quite active. Turns out to be very easy to find potentiators. And this was our best potentiator, this O2 compound. And then flashing forward 15 years, It turns out Galapagos's main lead compound in clinical development as a potentiator is this compound number 13, which is nearly identical to the very first compound we identified with small chemical modifications on the side rings. So right now, one potentiator, as you know, is approved, ivacaftor, and now it's approved for many different CFTR gating mutants, some of these very rare. And with Galapagos and other companies, we expect more potentiators to come on board in the coming years. But the more challenging thing, I said potentiators are very easy to find and work very well, but more challenging is the identification of a corrector. And the reason is to correct the mistrafficking, the misfolding of CFTR, we fundamentally affect many cellular processes. It's not simply binding to CFTR and opening it, which is what a potentiator does. Correctors have to do something more complicated, and what they do is probably very cell type specific. That is, a corrector that works well in the lung may not work so well in the GI tract. So again, our standard assay, cells with delta F508. In this case, we add a test compound for a whole day to act as a corrector and ask whether CFTR can be trafficked to the cell membrane. We then add a potentiator to amplify the signal, add iodide, watch the drop in signal, and look for compounds which, when added for a whole day, result in a more rapid drop in signal. So with that, we identified and published the first correctors in 2005 in the Journal of Clinical Investigation. And this is what the data looks like. So this is relative transport on the x-axis for different compounds. So control, meaning no corrector in red, gives a very small signal by short circuit current. The higher the signal, the more active CFTR. We identified 4 classes of correctors, and as shown in green, and in the green box on the right, we see that each of these compounds is able to increase the amplitude. And so basically, this is what a corrector does. We also reported the very first evidence that a corrector can work in real human cells. So these are bronchial cells from a homozygous delta F508 CF patient. Without the corrector, we see a very small signal with normal activators of CFTR, this bar here. With the corrector, there is, in this case, about a 2-fold increase in the signal that as CFTR is opened. Not extremely open. In fact, when you compare the numbers to wild-type non-CF bronchial cells, it was only about 15%. So not really necessarily therapeutic beneficial, but the first example. So based on the work we did and the optimization of compounds, a little later we, in 2007, licensed the whole portfolio to BioMarin, a small California company, to develop this. And unfortunately, they were not all that effective in developing the compounds. And as you know, the winner in terms of getting the first compounds out there was Vertex. And in 2012, ivacaftor became available. 2015, the combination of the corrector Vertex 809 with ivacaftor called Orkambi. Now, even before Orkambi was approved, it was widely known in the field that this would not be an ideal drug. This Orkambi did not work all that well. Fundamentally, all the correctors that have been identified by labs and companies, single correctors have relatively low efficacy. That is, they simply don't work very well. And the other specific issue with ivacaftor is that when incubated with cells, it reduced corrector action. Perhaps it binds so well to cells in CFTR that it does not allow the corrector to work properly. And so we and others discovered this, for example, this paper in Science Translational Medicine. Some gating correctors, including Vertex 770, diminish delta F508 functional expression. Well, it turns out this latter issue is a relatively easy fix because most of the correctors out there, including the Galapagos compound, don't interfere with corrector action. And we published this paper. potentiators of defective delta F508 gating that do not interfere with corrector action. So there are a number of development candidates that work quite well as potentiators but don't have this deleterious effect. The bigger challenge was the correctors not being very effective. And so what do you do about that? You look more, well, people looked more and couldn't find correctors. So the obvious thing is that if one corrector doesn't work very well, add another corrector. Hopefully two correctors would be better than one corrector. And it's actually a good scientific rationale. In this paper that we did in collaboration with Gergely Lukács in Montreal, our close collaborator, he discovered that certain chemicals affect certain parts of the molecule. And he drew this complicated diagram, which I have trouble understanding, but more simply stated is that with the delta F508 mutation, there's more than one distinct defect. One might be the folding of this nucleotide binding fold 1, where the delta F is located, and a second might be the interaction of this domain with the membrane-spanning domains of CFTR. And so if one corrector worked on one of these defects, a second on the other, there may be synergy or at least an additive effect of the two correctors. So to try to prove this paradigm, we developed a synergy screen. That is, we took cells, exposed them to a maximal amount of lumicaftor Vertex 809, and then together with a test compound asked whether the test compound could increase the efficacy beyond that of the Vertex 809 alone. And so this slide simply shows that our assay works in that the Vertex 809 could increase the signal. And we carried out the synergy screen, and indeed we found several classes of compounds that were additive or even synergistic with Vertex 809. As shown on the bottom, either by cell surface data, that is how much of the protein gets to the membrane, or functional data, how much it carries chloride, the maximal vertex effect is shown by the red line. So if we take the maximum amount of the vertex compound plus one of these new compounds, we go beyond the red line. And so this is the basis of triple combination therapy. That is two correctors plus one potentiator for delta F508. And this is the use of two correctors for real human cells from a delta F508 homozygous patient. This is the curve, going back, with vertex alone, with maximal vertex plus one of the new compounds. We see an increase in signal as quantified by the green bars at the right, showing the additive effect. So based on this, there's now multiple companies with triple combination therapy at various stages of clinical development. This is a partial list from the CFF website of where compounds are at. Of course, we know the approved Vertex compounds, and several others should follow closely. And these are some recent news releases from some of the companies working on triple combination therapy. So again, we see each of these talks about triple combination therapy, and the hope is, although it's too soon to know for sure, that triple combination therapy could confer significant demonstrable benefit with delta F508, which we haven't seen yet with Orkambi, which is a relatively small improvement in some patients. So going on with the 21st century, after working out combination corrector therapy, we became interested in drugs for the remaining 10% of CF patients. And what do I mean by this? So the vast majority of patients are either homozygous or have one allele with the delta F508 mutation. And as I said, the hope would be that a potentiator plus a combination of correctors would be effective for this group. But there's several other groups. First of all, the gating group, for which potentiators can be very effective. But of the remaining 10%, perhaps the most challenging are this half of the remaining 10%, 5%, in which no CFTR protein is made. And these are the nonsense mutations, also called class 1, in which there is an X, meaning that the protein is truncated and that the full protein is never made. And it turns out Of the 6 most common CFTR mutants that cause CF worldwide, 3 out of the 6 fall into this category of nonsense mutations, G542X, 1282X, and R553X. And the great hope was that read-through, the ability to read the abnormal protein and get a full-length protein would work. And as you may be aware, there was a clinical trial, several clinical trials with Adelaran, PTC-124, which was a read-through agent approved for some other diseases in Europe. But unfortunately, all of the clinical trials failed and work on this has been halted. And so getting a read-through to work in CF is a real challenge. But looking at these proteins, the G542X and the 553X are in nucleotide binding fold 1. And so if this stops the protein from being made, these two stop the protein from being made so early that there's no chance of getting any function. However, the 5th most common mutation worldwide, 1282X, the 1282 position is way down here. And so there was a possibility of correcting this. And this is what indeed we found, using potentiators and correctors for this mutation for which there's really no other therapeutic option. And this is work done by Pete Hagge, who spoke this morning in the research track, and so I'm sorry if I'm repeating anything he said. But we first looked at available correctors and potentiators. We made a cell line with this 1282X, and this gave very little chloride permeability, the red bar. If we add on Vertex 809 plus 770 plus forskolin, something that activates cyclic AMP, we get much more activity, the green bar. And combinations of these various compounds produce various amounts of activity. So this showed proof of concept that a potentiator and a corrector might be useful for CF caused by the 1282X mutation. So we did an assay to identify improved correctors and potentiators that were specifically good for 1282X. So we took cells with a 1282X, and as we did before, we did a corrector assay by adding a test compound. We looked at 50,000 such compounds for a day, then adding a potentiator to amplify the signal and finding compounds. Now, the interesting thing that came out of this was that if this is the signal for Vertex 809, a maximum amount, we can find compounds that work substantially better than the Vertex 809. And this is summarized on the right. On the y-axis is the relative activity for the 1282X. On the bottom axis is the relative activity for delta F508, defined as 1 and 1 for Vertex 809. The assay produced multiple compounds that work very well for 1282X, and they work less well for delta F508, CFTR. But at least there are correctors that appear to work very well. What about potentiators? So we needed a good potentiator because the real problem was the gating. Potentiator screen, unfortunately, did not work very well. We didn't find anything nearly as good as the Vertex 770, ivacaftor. But Pete did make a tremendous discovery, quite accidentally. Here we add one of our potentiators, which produces almost no signal. Then after that, he added Vertex 770, expecting to see the maximal signal, which we knew from other experiments should be about this much. But instead, he found a nearly 10-fold increase in signal. So it was an unexpected, remarkable synergy between two potentiators. And we call the second potentiator a co-potentiator. And so in this case, it doesn't make any difference whether you add the Vertex 770 or the new compound first. In this case, we added the Vertex 770, saw the expected very small signal, added our new co-potentiator, and found a very large signal. And we think this paradigm of co-potentiators, that is, combination of potentiators, will be key to treating some of these very difficult refractory CFTR mutants. And we don't at this point know the molecular mechanism, but we could draw a cartoon. Here we have a poorly folded CFTR with a misfolded nucleotide binding 1 and 2. One potentiator might correct one of these misfoldings. The other potentiator correct the second, and both together therefore conferring much more activity than one alone. And we're trying to work out the molecular mechanisms, but we don't know yet. What we also do is nutraceutical and approved drug screens, because if we could find a compound that's already in the health food store or approved for a different indication, that would tremendously fast-track its application to CF. And by this kind of co-potentiator screen of nutraceuticals, interestingly, we came up with this compound, apigenin, which is a plant-derived compound available in health food stores, as shown here. And this compound, like our compound, greatly acted in synergy with Vertex 770. And of course, the bad news, unfortunately, is that the amount you need is probably 10 to 100 times that of the normal blood level if you take this as a nutraceutical, even in high amounts. So certainly I'm not saying anybody should go out and buy apigenin, but it does illustrate the possibility of capitalizing on what's already known in terms of existing drugs or nutraceuticals. And we have other candidate molecules as well. So the question is, what does it do in real human cells? And it's been very hard to come by because they're relatively rare in the United States, delta F W1282X homozygous cells. And we found, using cells from one patient, unfortunately, absolutely no effect of any of the compounds. And we assume, we believe this is due to patient-specific factors, and because I'll come back to in a few minutes, a different patient where we did see some activity. But let me come back to the no protein remaining 5%, and as well as the residual function 5%. The fourth most common mutation worldwide is N1303K, present primarily in the Italian population. This, like delta F508, is very poorly trafficked and gated. And unlike delta F508, it does not respond well to existing potentiators and correctors. But we found recently that a co-potentiator strategy could be useful for the 1303K. This was published last month in the Journal of Cystic Fibrosis. And this is the same kind of co-potentiator strategy we used for the 1282X. This is our co-potentiator, Vertex 770 alone in cells expressing N1303K. With our co-potentiator, a remarkable increase in signal, much more than adding compounds individually. It not only works for N1303K, but it works for a variety of other CFTR mutants as well. For G551D, even if we add maximal Vertex 770, adding the co-potentiator increases the signal, sometimes double, beyond that of the standard potentiator. And this is data from real human cells. This is data from a patient in Italy with that's homozygous for the N1303K mutation using human nasal cells. And the finding is that Vertex 770 alone produces some effect. This is all in the presence of a corrector. And our co-potentiator, as shown in the green bar on the right, increases the effect further. Now, coming back to, as I promised, 1282X. So we had one patient that's compound for 1282X and G542X, the latter unable to produce any protein. And here we did see an effect of our co-potentiator. And so we're very interested in obtaining more cells, and we're searching the world to obtain patients with the suitable genotypes. So what about personalized medicine? It's become very popular to think about doing screens and doing theratyping. So personalized CF medicine has been called N of 1 medicine, or theratyping, finding a therapy that's specific for one patient. And there's a number of challenges as listed here. And materials are always a problem. I think by far the best are nasal epithelial cells, because the intestine is not the airway, and the airway is where the real serious pathology occurs in CF. So this is one example of theratyping. we have a local family that has 1282X together with a rare mutation I1234V. And we took nasal cells, we tested therapeutics. We found first that correctors did not help. Correctors actually made things worse. Vertex 770 produced a small effect, and our compound, or apigenin, as a copotentiator, further increased the level. Still not all that much, but at least showing the possibility of doing patient-specific theratyping. But the real goal is to do large-scale screening on patient cells. That is, take a single nasal brushing from a patient and look at even tens of thousands of compounds. And we're clearly not there yet, but we've moved forward in the technology. This is a paper we published last month in Analytical Biochemistry, a hollow micropillar array method for high-content drug screening on filter-grown epithelial cells. And the way this works is we microfabricate what's called a micropillar array of hollow cylinders containing holes, as shown on the right in a scanning electron micrograph. We fill using a hydrogel each of the holes with a different test chemical. We then contact all of the chemicals with a cell layer, then do an assay by imaging, and then figure out what area of cells was active and determine what compound was in the pillar just over those cells. And one example showing a CFTR activator, which was added to every fourth micropillar in a 10 by 10 pillar array, which is only 3 millimeters. And by expanding the size of the array to 1 or 2 centimeters, we can in principle screen 10,000 compounds at once, although there's a lot more technical to do in this. So with this, we have cautious optimism about CFTR modulators. That potentiator corrector combinations may be useful potentially in the fairly near future for most CF patients. But I want to be cautious because the CF field has been burnt many times. Some of you may remember back in the early 2004, curcumin, the Indian spice, was said to be the answer to CF. And within months following this paper, we and multiple other groups found that this is not the case. Curcumin does not work to open CF. Even last year, thymosin, a natural product polypeptide, was the magic cure that appeared to do everything to CFTR, another thing which is too good to be true. And again, recent 2 papers from very good labs showing that there's no effect of the thymosin 1, and I assume more papers will come out. In the mid-1990s, adenoviral gene therapy from the IO group showing correction of the nasal defect. And it was thought and widely said that CF would be cured within a few years. And this was, what, 1993. And now 25 years later, one is arguably not much further along in gene therapy now than in 1993. So what's left? So what if none of these things work? What else might be useful? So in terms of disease-modifying CF therapies, that is, therapies that fundamentally affect the disease process. Besides modulators, there's replacement gene therapy, or modulators of other targets. And the scientific rationale is try to correct specific defects. In the lung, the airway surface liquid in the normal lung is very thin, non-viscous. In the CF lung, it becomes thickened, and mucociliary action does not occur. So one approach is to inhibit the epithelial sodium channel, inhibiting sodium uptake, and thereby increasing the ASL depth. And there's at least a half dozen companies with ENaC inhibitors at various stages. But we've been interested in the bottom 2. One is pendrin. Pendrin is a chloride bicarbonate exchanger expressed in the inflamed airways. By inhibiting the uptake of chloride, just like by inhibiting the uptake of sodium, one could in principle increase this fluid layer. So we did a high-throughput screen, identified compounds, and found compounds that inhibited pendrin very well, as shown by the red and green bars here on the left, and that increased the ASL depth. And we're currently looking for partners to move this asset forward. Another thing is TMEM16A is a calcium-activated chloride channel expressed as shown here in the airway submucosal glands that produce thin, non-viscous fluid onto the airways. We did a screen, found compounds, and found that the compounds increased airway fluid. So this is another possibility that needs clinical development. So now let's say nothing works. None of the disease-modifying therapies work. What are we left with? So we're left with non-disease-modifying or supportive therapeutics. And obviously these have been very effective because they increased the median life expectancy in CF from age 2 in 1950 to age 40 in the United States now, and over 50 in Canada and many European countries. And these are some of the various drug types that are being advanced. And in the last few seconds, I just want to tell you what we've done recently to combat constipation in CF, which many of you know is a major issue. Nearly half of CF patients have constipation at some point, often severe, and constipation can cause life-threatening diseases as shown here. So our target, which can't be CFTR, obviously a CFTR activator as shown at the beginning, cannot be used to treat constipation in CF because there's no functional CFTR. So we use something called DRA. It's a chloride bicarbonate exchanger in the colon, which normally absorbs fluid from the colon. And the rationale is by inhibiting the fluid absorption, we could treat constipation. So to make a long story short, we developed and carried out a high-throughput screen, did medicinal chemistry, optimized a compound, found it had low nanomolar potency for inhibition of DRA-mediated chloride bicarbonate exchange, and showed that it worked in a CF mouse model of constipation, shown by the green bars. This is a constipation model produced by Imodium, loperamide, an opioid, which decreases greatly stool weight, pellet number, and stool water content, and this was normalized partly by our compound. And we published this actually last week in a Journal of Clinical Investigation Insight and talk about the utility in CF constipation. And we filed a patent and are looking for commercial partners or additional sources of funding. So to conclude, I think the future is very promising, both as I discussed for CFTR modulators that are mutation-specific, as well as mutation-agnostic therapeutics, disease-modifying and non-modifying, as well as CF gene therapy. So with that, I'll acknowledge my collaborators who did the work, both outside and at UCF, and various funding sources, and I'll be glad to take any questions. Thank you.